Right, it's almost 8:05. Again, a very good morning to everyone. Welcome to this this week's first UCT-Africa virtual platform presentation. Today, Nathaniel van Wyk, Chief Dietitian at the University of Cape Town and Groote Schuur Hospital, is presenting, and he's involved in the care of head and neck patients and is speaking on a very important topic of the nutritional considerations in head and neck patients. Just a few house rules. Please, a reminder to everyone to keep your microphones muted unless you would like to post a comment or ask a question after the meeting. Please post your name and institutional details on the chat function below. And also, please feel free to post any questions you may have on the chat function. Nathaniel, would you like to share your screen?
Yes, will do, Kevin. That's fine. Can everyone see?
Excellent, Nathaniel.
Good morning, everyone. Good morning from Cape Town. As Sharat introduced me, I'm Nathaniel van Wyk, Chief Dietitian at Groote Schuur Hospital. So today we will be talking about the nutritional considerations for head and neck cancer patients. So the contents that we're going to cover for today is a brief introduction into nutritional management of head and neck cancer patients, looking at malnutrition statistics, talking a little bit about the terminology with regards to cancer and nutrition, looking a bit at the pathophysiology, the ABCD approach that is normally followed in dietetics, and then just a brief conclusion. Okay, so jumping into it. So approximately 35 to 65% of all patients with head and neck cancer are malnourished at the time of diagnosis because of tumor burden and obstruction of intake, or the anorexia and cachexia cause associated with the cancer. And that is quite a significant number of patients. And this is mostly European studies. In our South African population, the malnutrition statistics might even be a little bit higher. So the terminology that is normally used in cancer-related malnutrition is disease-related malnutrition, and that has been defined as a condition that results from activation of systemic inflammation by an underlying disease such as cancer. So cachexia and pre-cachexia, so normally pre-cachexia is early clinical and metabolic signs that precede extensive involuntary weight and muscle loss. The cachexia itself is a multifactorial wasting syndrome that is characterized by involuntary weight loss with ongoing loss of skeletal muscle mass, with or without the loss of fat mass. Then the one that is frequently overlooked is sarcopenia, which is a low lean body mass, mostly muscle, and fatigue is common. In strength may be lessened and physical function may be limited. If you look at the picture in my right-hand corner of the patient that sort of looks overweight, but the lean body mass that is lost through muscle is quite significant. And that is typically in our population, in our global population now, with this phenomena of double burden of disease, of malnutrition and obesity. And the obese patients are sometimes more prone to sarcopenia. Okay, and just looking at the three put together, because they're sometimes interlinked, So anorexia is associated with poor food intake, by altered CNS appetite signals with symptoms resulting from cancer or its treatment. And the typical symptoms is nausea, diarrhea, and pain, which leads often to diminished food intake. And then physical limitations to food intake and use, which we often see is mouth ulcers and GI obstructions. And then pre-cachexia and cachexia, the weight loss are worsened by catabolic drivers of inflammatory cytokines that further reduce nutrient intake and metabolic needs. And then sarcopenia ensues as body reserves are depleted and lean body mass, mostly muscle mass, is lost. We will look into these pathophysiological drivers a little bit more in detail after this literature review. So I did a quick review of the literature, and as you can see, most of the studies are in the European countries, and there's very little data available in sub-Saharan Africa on the malnutrition prevalence of hospitalized patients with cancer. But looking at this literature, as you can see, the malnutrition prevalence is quite significant at diagnosis and throughout the continuum of care, which ranges from between 25 to 75%, and the higher number of these patients are severely malnourished, which means they probably have a body mass index of lower than 16%. Interestingly, one of the ENT registrars at UCT is currently busy with the protocol phase of looking at the malnutrition prevalence in hospitalized patients in and around the Western Cape. So those results will be quite interesting to see comparative to the international studies. So I just had a quick look on the European Society for Metabolic and Clinical Nutrition, and they had a quick look at the financial impacts of malnutrition on these oncology patients. And the higher the malnutrition rate, the more significant longer length of stay, with more than 3 days, and the higher cost of care. And as we know, the global burden of the higher cost of care is not something that is that we sort of need at this stage right now, because it has quite a significant impact, especially in developing countries as well. And then malnourished patients also have significantly higher risk of surgical site infections compared to well-nourished patients. The p-value, as you can see, there is less than 0.0001. And then malnutrition predicted lower tolerance to chemotherapy and was associated with greater risk of mortality as well. Then severely malnourished patients were a fourfold higher risk of 2-month mortality than well-nourished patients, which I think is quite a significant higher risk of malnutrition, of mortality, sorry. So I think that looking at this malnutrition data, it is important that we identify these patients early and get a nutrition profession involved to help not necessarily limit the disease progression, but help these patients tolerate treatment better, be preoperatively optimized for surgery, and then post-operatively as well, helping these patients regain the lean body mass that they lost throughout the process. And then having a quick look at the pathophysiology. So patients with cancer cluster symptoms that can be related to poor nutrient intake, weight loss, and declining physical function, as well as fatigue, pain, and depression. And such symptoms have also been associated with reduced quality of life and survival in these patients with advanced disease. In fact, there is a consistent association between symptoms, the presence of inflammatory markers, and upregulated immune responses. So as you can see, the systemic inflammation causes anorexia. It causes weight loss and poor function. It causes fatigue and pain, and as well as depression. So further systemic inflammation can be provoked by spillover of pro-inflammatory cytokines produced by the tumor. For example, TNF-alpha, interleukin-6, and interleukin-1. And in turn, these pro-inflammatory cytokines disrupt metabolism of carbohydrates, fats, and proteins in the body. So in the brain, it alters appetite signals from the central nervous system, and it then causes anorexia, resulting in reduced caloric intake. And in muscle, an anabolic catabolic imbalance leads to muscle wasting, and then reducing muscle strength and increasing fatigue. Looking at the liver, in the liver, acute phase protein production is stimulated, and repressing drug clearance and raising the risk for cancer treatment toxicity. Looking at fat stores, fat as an energy store energy stores in fat deposits are depleted as cytokines stimulate increased lipolysis and cause defective lipogenesis, a maladaptive and wasteful response to low food intake. Looking at the ABCD approach. So nutritional assessment serves as the basis for malnutrition diagnosis. It looks at the cause, the severity, and the type. And there are a number of different screening tools that can be used in nutritional assessment of these cancer patients. The most frequently used nutrition screening tool in oncology patients, although it's not oncology specific, is the patient-generated subjective global assessment. We'll look into the screening tool in a little bit more detail. It is a 4-in-1 instrument that does nutritional screening, assessment, interventional triage, and monitoring of interventional success. And I think personally the beauty of this tool is because it's so comprehensive, it looks at the patient post-discharge as well. It will give us a clearer picture if the patient comes for follow-up 2-6 months down the line. So looking at the scored patient-generated subjective global assessment. So the first page of the assessment tool, a bit of a busy slide, the first page of the assessment tool is patient-generated. So the patient fills out this form. The terminology used is quite simple and understandable for patients. There are a number, this tool has been revised quite a number of times as well. And it has been made specific to populations around the globe. So looking at box 1, it basically gives a quick representation of what the patient's current anthropometry is, and if there was any weight changes during the past 2 weeks, 1 month, and 6 months. Looking at box 2, it gives a quick indication of diet history of food intake. I think this is also specifically important for dietitians as well. So it asked if there was any changes in food intake, if it's more than usual, if it's less than usual, unchanged. And if these patients are using any extra forms of nutritional support. And each of these questions then generates a score, which is supposed to be filled in at the bottom of the box, where box 1, box 2, 3, and 4 is indicated. And then box 3 looks at the symptoms that the patient, if the patient had any symptomatic changes during the past week that inhibits the patient from eating enough. So it looks at appetite changes, it looks at nausea, mouth sores, constipation, taste changes, and swallowing problems. And then a very important box as well, box 4, speaks on patients' physical activity and function. Here, basically, it gives us an indication of did the possible weight loss cause any limitation in terms of patient physical activity and function. And then in the bottom corner, it then gives a total score. And this the patient can fill in while waiting in the waiting room to be waiting for consultation. And it can be handed in. And then the second part is completed by the clinician, which is also quite a busy form, but it gives us a clear indication of any changes in physical exam, in nutrition status, and so forth. So if we look at worksheet 1, it gives us a scoring of the significance of weight loss over the past month or 6 months. So there's a scoring system in there that the patient can be scored on based on the weight loss that the patient experienced, possible weight loss that the patient experienced. And this can be determined if there was any previous weight 1 month prior to the current consultation, or perhaps 6 months. So it can be compared to the weight on the day of consultation, and the percentage score can then be given. On worksheet 2, gives an indication of disease and its relation to nutritional requirements. So obviously, any of those boxes there places the patient at an increased nutritional need. For example, cancer, AIDS, pulmonary and cardiac anorexia, pressure ulcers, open wounds and fistulas, and the pressures of trauma. And then also our elderly population are also at a greater risk for malnutrition. Then worksheet 3 looks at the metabolic demand, which we do in our daily clinical assessment. It looks at the patient at any fevers and what the duration of the fevers was. Looks at the patient if the patient is on any steroids, and that also generates a score then. The worksheet 4, the clinician will have to do a physical exam to determine the patient's muscle status, to see if there was any temporalis muscle loss over the pectoralis and deltoid region, to see if there's any muscle loss there, interosseous muscles, scapula, thigh, and then calves as well. And this gives us a global muscle status rating. Something that dietitians often use, not as much today in clinical practice anymore, but also a determinant of any changes in muscle mass is triceps skin folds, and then also looking at fluid status of the patient. And this thing gives us a global assessment if the patient is well nourished, moderately malnourished, or severely malnourished. And based on this, we can follow up the patient over a period of time and intervene as needed. So as you can see, the triage based on, it's very small in my right-hand corner, the triage based on patient subjective global assessment. If the patient scored 0 to 1, there's no intervention required at this time. 2 to 3, patient and family education by dietitian, nurse, or other clinician. And then if the patient scores between 4 and 8, the patient requires intervention by a dietitian in conjunction with the nurse or physician as indicated by symptoms. And if the patient scores more than 9, it indicates a critical need for improved symptom management and a nutrient intervention option. Okay. Taking a look at the biochemistry. So several biomarkers exist for testing of nutritional status. Traditionally, albumin, prealbumin, transferrin have been used. However, no single marker measures nutritional status accurately. Albumin is a major protein produced by the liver with a normal range of 3.5 to 4.5 grams per deciliter. So the function of albumin is a major carrier protein, and it preserves intravascular oncotic pressure. So the half-life of albumin is 20 days. Therefore, it reflects acute changes in nutritional intake and status very poorly. But it is, however, it remains a defining factor in starvation and is the best serum marker to correlate with lethality rate. So it is, therefore, yeah, it's not a very good biomarker for acute changes in nutritional status. Looking at transferrin, so major ion transport protein and has a circulating half-life of 8 days. Iron metabolism and nutritional status affects its production, which may decrease its reliability as a nutritional status marker. Looking at free albumin, it is also synthesized by the liver and range from 15 to 25 milligrams per deciliter. It also transports hormones and proteins in serum and has a half-life of 2 to 3 days. Nutritional depletion is reflected sooner by changes in free albumin than by albumin. Although changes can be seen sooner, fewer studies have validated its usefulness over albumin to predict outcome. And in several conditions such as renal insufficiency affect free albumin plasma levels. So looking at the table on the screen, the biomarkers that is used to assess the patient's nutritional status. So an albumin of a range between 3.5 and 2.8 grams per deciliter indicates mild malnutrition. 2.7 to 2.1 indicates moderate malnutrition, and below 2.1 indicates severe malnutrition. Transferrin level between 200 and 151 milligrams per deciliter indicates mild. 150 to 100 indicates moderate, and below 100 indicates severe. And then looking at a total lymphocyte count, lower than the range of 1,200 to 1,500 per cubic square meter without reason for immunosuppression is another indicator of malnutrition as well. Looking at our clinical assessment, we normally look at the speech and language pathologist, look at the patient's ability to chew and swallow, and then liaise with the dietitian if any other interventions are needed. We also look at the clinical signs of weight loss, for example, ill-fitting dentures or clothing. And then we look at the easiest clinical or indicator might be the body mass index, which might be the easiest to do in a busy clinical setting, which basically takes the patient's weight and divides it by the height squared, and that gives us an indication of the patient's nutritional status. A BMI of below 18.5 to 17 indicates mild malnutrition. 16 to 16.9 moderate malnutrition, and below 16 indicates severe malnutrition. And then skin fold, as mentioned earlier, skin fold thickness indicates fat stores. And then mid-upper arm circumference indicates lean tissue mass. But mid-upper arm circumference might be a tricky measurement to use, as it has no proper clinical value in overweight patients, especially of the BMI more than 30. And then hand grip strength assesses muscle function as well. Looking at the patient's dietary requirements, so normally the literature shows that we should aim for an energy intake of at least 25 to 35 kilocalories per kilogram. And then a protein intake, although some studies have shown very liberal protein intakes, most studies coming to the fore has shown that a higher protein intake of between 1.5 and 2 grams per kg has shown significant clinical benefit. And then severely depleted patients, we should initiate feeds slowly over several days while monitoring phosphate, potassium, and magnesium levels to avoid potentially harmful refeeding syndrome. You can have a little look at refeeding syndrome that is often used in the dietetic fraternity. The doctors mention it, but do we truly understand the effect of refeeding syndrome on our patients? So oncology patients normally, especially head and neck cancer patients as well, suffer from long periods of starvation or malnutrition. And this leads to glycogenolysis, glyconeogenesis, and protein metabolism, which then in turn leads to protein, fat, mineral, and vitamin depletion with salt and water intolerance. So then we introduce nutrition to the patient, the so-called refeeding, where we're trying to switch the patient from a catabolic to an anabolic state. And this major introduction of glucose causes insulin secretion, which then leads to increased protein and glycogen synthesis, which then in turn causes an increased uptake of glucose by the cells, increased utilization of thiamine, and increased uptake of potassium, magnesium, and phosphate, which then leads to intracellular hypokalemia, hypomagnesemia, and hypophosphatemia, thiamine deficiency, and salt and water retention, which causes edema. And this leads to the refeeding syndrome, which is often in clinical phenomena patients goes into cardiac arrest, etc. And then how do we manage refeeding syndrome from a nutritional perspective? If the patient is at the risk for refeeding syndrome, we check the serum potassium, calcium, phosphate, and magnesium levels. And then before we start feeds, we administer thiamine 200 to 300 milligrams daily orally, or vitamin B, high potency 1 to 2 tablets 3 times daily, or full IV dose of vitamin B, which might be the easiest in the clinical setting with regards to absorption and so forth. And then a multivitamin and trace element supplement once daily. We start feed slowly at 10 kilocalories per kg per day. But if the patient is severely malnourished, we start even slow. We start at 5 kilocalories per kg per day. And then we slowly increase it over a period of 4 to 7 days. We rehydrate patients carefully and supplement and or correct levels of potassium, phosphate, calcium, and magnesium. We also then, with the supplementation, monitor the serum levels of potassium, phosphate, calcium, and magnesium for the first 2 weeks, and we then amend treatment as appropriate. So methods of nutritional administration. So we first always try the oral route, if oral intake is possible, with the help of oral nutrition supplementation. And if oral intake is less than 60% of caloric needs, we do intro feeding. Feeding tubes are placed into the GI system, effectively bypassing the affected areas. And then, if feeding tubes are to be used for more than 7 days, or if we, from the beginning, if we use feeding tubes, the feeding tube material should either be polyurethane or silicate tubes over polyvinyl chloride tubes, as these tubes have been found to be softer and is a small bore, which causes less nasal irritation and lower esophageal sphincter compromise. So how do we select our formulas when we do nutrition support? So it has often been found due to the severe symptoms that cancer patients experience. Smaller volumes are often better. Smaller volumes, nutrient dense, high protein feeds are often better tolerated. And if we do oral nutrition supplements, it should preferably give at least a requirement of 400 kilocalories and 30 grams of protein. If oral intake is not possible, we go the intro route. There are a number of formulas available for intro nutrition. We often think literature has shown that no one formula is superior, and we can start with polymeric formulas. We should always look at the osmolality of the feeds, because this then affects the patient's ability to tolerate the formula. So we do isosmolar formulas. Here as well, we will look at a nutritional composition with higher caloric content and high protein content. There's been a lot of studies looking at immunomodulating components as well for enteral nutrition, such as arginine, omega-3 fatty acids, glutamine. But none of the studies have shown conclusive results in terms of bettering patient mortality rates, but it will reduce might reduce post-operative complications. And then parenteral nutrition is a very, very, very last resort that we don't often use. So it is total parenteral nutrition is IV nutrition, intravenous nutrition, and that is used as a very last resort when enteral nutrition is not possible. Looking at quick post-discharge follow-up, I think this is very, 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 very important for all our patients to have a proper post-discharge follow-up plan involving the multidisciplinary team, the clinicians, the dietitians, the nurses, the speech therapists, and liaising regularly in that multidisciplinary team will ensure that the patient's 6 months post-discharge might have increased 6-month post-discharge mortality benefits. And then what we often do in South Africa with patients post-discharge and requires nutritional intervention, we place them on the nutritional therapeutic program, which is a program where we provide nutritional supplementation for a period of up to 6 months, depending on the patient and depending on the progress made over that period. And here we will follow up the patient as required, bi-monthly or monthly, and intervene when needed. And then, yeah, as I said, regular follow-up is very, very important. Bringing the presentation to a conclusion for the few take-home messages. So despite numerous advances in treatments and care for people with cancer, malnutrition remains an unresolved issue. And then another important fact is that dietitians should be a part of the multidisciplinary team for treating head and neck cancer patients throughout the continuum of care, as frequent dietetic contact has shown to have enhanced outcomes. So throughout the continuum of care, it means pre-operatively to optimize the patient for surgery, and then post-operatively as well to build up the patient with the help of the speech therapist as well, and advancing the patient to go back to oral nutritional intake. But post-operatively, the patient often requires tube feeds, and the early referral to a dietitian will ensure that the patient receives early enteral nutrition, which has been shown over and over to have positive outcomes on these patients. And then very important as well in the clinics to screen all patients with cancer for nutritional risks early in their course of care, regardless of body mass index. Like I mentioned earlier, the obese patients with sarcopenia, and yeah, regardless of weight history as well. So regularly rescreen nutritional status, and as I mentioned with the patient-generated subjective global assessment, it's a nice basis to use when you do the rescreen to see if there was any changes in nutritional status. And then increase nutrition assessment to include measures of anorexia, body composition, inflammatory markers, resting energy expenditure, and physical function. And then use nutritional intervention with individualized plans, hence again referring to dietitian, including care focused on increasing nutritional intake, decreasing inflammation and hypometabolic stress, and increasing physical activity. And with that, I thank you.
Nate, thank you very much for a very comprehensive talk. I would like everyone to please post any questions. If you have any questions, please raise a hand or post it on the chat function. Nate, I would please like to ask the first question, and I would just like to know how one would consider high-density caloric and protein feeds in a developing setting where there are no formulas available for patients. And I would also just want to ask your take on multivitamins, and lastly on indications for parenteral feeds in head and neck patients.
Thank you for the questions, Janet. So looking at a high density caloric feed in limited settings. So it is often found that the complete formula is not necessarily available in those settings, but there is, however, the nutritional modules that we call it, so modular feeds that we call it, and those are available in different type settings. So with nutrition modules, I mean you get a separate carbohydrate component, you get a separate fat component, you get a separate protein component that you can use with a standard feed that you have available to increase the protein and energy content of that specific feed in the limited setting. So the complete nutrition supplement or internal nutrition formula might not be available, but those modules can be used to bring your specific feed up to that caloric and protein content. Multivitamins. So a lot of these, there's been no benefit proven over using early multivitamins in cancer patients. It does not improve outcomes. What we normally recommend is a balanced, complete nutritional intake. So multivitamins has not been shown to improve outcomes in head and neck cancer patients. Then parenteral nutrition. So parenteral nutrition, you would consider if there's absolutely no GIT excess. So if, for example, in the setting where the patient has lost its small bowel excess, with regards to progression of disease as well, so the patient has lost small bowel function, then in that case you would consider parenteral nutrition. But if the patient has not lost small bowel function yet, and there's a gastric tube can't be inserted, an open gastrostomy can be done, or feeding jejunostomy can be considered in that case as well. I hope that answers your question.
Thanks, Nate. Prof. Fagan, would you like to add anything to nutritional considerations?
Yeah, thank you very much for a really, really good presentation. you know, I think it's an area that we haven't really managed very well over the years, and so we've always welcomed the active involvement of dietitians in our patients, because I think a lot of patients present malnourished not just because of the tumor, but also because of pain, because patients simply can't swallow, and thirdly, that they often come from very poor communities where they and their families are in fact malnourished. And so the first question is, how long does it take to actually sort of restore a patient's nutritional status? Someone who's awaiting treatment, so I can counter some of those negative effects in terms of patient management and outcomes from malnutrition.
So, Prof, a lot of the studies have shown pre-operative nutritional intervention you won't necessarily restore the patient's nutritional status, because that depends on the severity of the malnutrition as well. But nutritional intervention for up to 2 weeks pre-operatively has been shown to have positive post-operative outcomes on these patients.
Okay, so we have to give it at least 2 weeks to try and so-called feed up a patient. There are a few studies that we really have to look at. The first is, as you said, I think we should assess the nutritional status of our head and neck patients coming through. Secondly, so what happens to our patients' nutritional status while they're awaiting treatment, because they might wait 2, 3, 4 weeks or 5 to 6 weeks sometimes for their treatment to start, whether it's radiation or surgery. So it'd be interesting to see what happens in that window, and whether nutritional support makes a difference. Then perhaps Dr. Dalby, if she's still on the call, she can also comment on the relationship between their nutritional status and the ability to complete their radiation treatment. Because some patients simply don't complete their treatment, and the question is whether that's associated with the nutritional status. And then Dr. Witt has also commented that we've had quite a few patients who developed osteoradial necrosis. That's where they have a fibula sort of reconstruction of the mandible, and that the fibula sort of breaks down some months or years after surgery. The question is whether their nutritional status has something to do with that. And then we can also look at our acute complication rates in terms of fistulae. So after surgery, for instance, laryngectomy, to see whether there's a correlation there. So I think there are quite a few areas of collaboration that we can look at, and that's all going to hinge on the nutritional status. Perhaps Samira would like to comment, if she's still on the call, in terms of patients completing their treatment, depending on the nutritional status.
Yes, thank you, Jan. Yes, I agree with comments. We do find that the head and neck or ENT patients, they do struggle to finish their radiotherapy. It's sort of a multi-pronged problem where the patients, because they're not eating enough, they become weaker, and sometimes we have to give chemotherapy with the radiotherapy to improve efficacy and survival, but we're not able to give it because they can't tolerate it. And then the other problem is when they lose weight, the cast which immobilizes them when they are having the treatment doesn't fit, and that also has quite a significant impact for us, because it obviously changes the area that's being treated and the dose that's being treated, because it's absolutely crucial in head and neck radiotherapy that the patient can't move or is effectively immobilized. So what we also find is that the dose to the skin and other crucial organs at risk might be higher than what we thought, and that our treatment is not what was planned. So I do find, and especially if one uses these more advanced radiotherapy techniques, such as MRT, which is quite unforgiving if there are any changes in the patient's contour. previously we had done 3D conformal radiotherapy with much bigger margins, and there was sort of some sort of leeway or give if the patient lost weight. But we don't have that if we do MRT. So it's absolutely crucial for us that the patient is able to maintain their weight on radiotherapy, and that there's no change in the body contour, especially over the head and neck area, which needs to be immobilized and the class needs to fit. So I think that collaboration between all our disciplines is crucial. We need our own data. We need to know what's happening with our patients and how we can improve their care and outcome. Thanks. I don't know if Nathaniel wants to comment on that.
Thank you, Dr. Dalby. I think, yeah, what you mentioned is really very important, and that multidisciplinary collaboration is needed. We will definitely need our own data to see our patient population, because I think we also have a unique patient population in terms of poverty, poor socioeconomic circumstances. Looking at those more other interventions are needed to ensure that we optimize this therapy as well. So I think we should definitely get started looking at how we can improve our patient outcomes.
Thanks, Nate. There's a question on the chat function from Jian Mulanga. She's asking, from your experience, how long that it is to take for severely malnourished patients to manage to start cancer treatment, if you would ever combine enteral and parenteral approaches to speed up nutritional improvement. Would you ever do that, Nate?
Okay. So we always choose, if so it's sort of statement in the dietetics fraternity is, if the gut works, use it. But if, for example, you do a enteral feed and the patient can't tolerate increased volumes, there's intolerance with regards to vomiting or decreased gastric emptying or diarrhea, for example, you try all different enteral modalities and you still can't reach any success, then we would consider supplemental parenteral nutrition to help in that period of build up to surgery. Okay. But we don't often do it.
Okay, thanks, Nate. And then I see we've got a raised hand from Alice Ziyaba. Alice, would you like to go ahead and ask a question?
Hello.
Hi, Alice, we can hear you.
Yes, thank you for the great presentation. I'm a dietitian from Ghana and Konfanachi Teaching Hospital. And there was a question on the high calorie formulas, or how do we get that delivered? In our setting, or generally in resource poor settings, we don't normally have the access to these standard formulas like he mentioned. And when they are available, they tend to be expensive. So what we do mostly in Ghana is that we use the blenderized tube feeds. And that's what works for us. So the main challenge using this is that because the tubes are much smaller, you may have to feed smaller volumes and more frequent feeds, so that at the end of the day, the patient is able to achieve all the nutrient needs. And then we also do a combination of the blenderized feeds plus high calorie snacks. They may come in the form of milk-based drinks, or we have protein powders in situations that the family can afford. Our main challenge has been referrals that the multidisciplinary team approach that he mentioned is very important, but in most of the cases, before the dietitian is involved, it takes a long time. The time that the dietitian is called, the patient might have been severely malnourished, and then at that time, there is not much that you can do. So I just want to encourage, especially our clinicians, to do the early referrals and involve the dietitian at every point of the management. Thank you very much.
And then, Nate, one more question. There's a question from Eunice. If you can just clarify one last time the trace elements in the PowerPoint and multivitamins used in head and neck patients.
Okay, so I think that the trace element component was specifically referred to in the refeeding syndrome management approach. As mentioned earlier, with regards to the multivitamins in head and neck cancer patients, there's no conclusive evidence that it has any beneficial outcomes in terms of mortality benefits and also reducing infectious complications. So higher doses of certain vitamins has been shown to possibly reduce infectious complications, but the evidence remains inconclusive.
Could I make a comment?
Absolutely. Please, Prof.
I think what Alice raised there, I think, is a very important issue because formula feeds simply aren't available or are not affordable for so many people around the world. And it might be good for her and Nathaniel to collaborate and to write a paper on how I do it. But certainly we can get that published because I think it will have great relevance. And I'd urge her to look at that and to see what the issues are in terms of what type of formulas, what type of tubes. I know Ross Denton always said that when you're doing a pig, you must put in a big tube, not a small tube, so people can blenderize and they can feed. And I think these are all very important practical issues. So I'd urge her to collaborate and to see what we can do.
Thanks, Prof. I'll just ask Alice if you can please just post your email on the chat function so we can forward that to Nathaniel. That would be a really excellent study and a first for developing countries. Our time has run out for this session. I would like to thank everyone's participation, and remind everyone of this Friday's upcoming African Head and Neck Society Tumor Board meeting, which is always a highlight of every month. So we look forward to seeing you there at 6 South African Standard Time on Friday. Thanks, Nathaniel, for excellent presentation. And Alice, I please want to remind you just to post your email on the chat function for Nate. Thank you so much.